Good evening, respected doctors. My name is Ramanuja, Zonal Manager from MSN Labs. So on my personal behalf, on behalf of team MSN Head Office, I welcome you all to today's session on the first oral prostacyclin analog, that is Selexipag. So before we start the session, I would like to give a brief introduction about MSN Labs. Innovation resonates a sense of purpose in the evolution and existence of human life. The creative capacity of a human mind has always been the source of inspiration. We believe every life matters and everyone deserves quality medicine. Apart from the efficacy, affordability, and accessibility, we want to be the first to touch and impact human lives. We are MSN, Research for Better Medicine. Coming to MSN's global research portfolio, MSN has got Asia's largest pharmaceutical research center with 1,400 team of dedicated scientists, 42 scientific labs, and 2 pilot plants, making it Asia's largest R&D. MSN has got 17 world's first branded generics launched in last 1 decade and 690 patents for API and formulation innovations. Coming to global quality manufacturing, MSN has got advanced global approved manufacturing site, 11 in India and 1 in USA. MSN has got 30 plus approvals from leading authorities of world, including US FDA, UK, WHO, and many more. MSN has got 300 plus bioequivalent formulations, 450 plus APIs manufactured. Coming to MSN's global presence, MSN is truly indigenous, having global research presence in more than 65 countries across the globe, with 410 plus global leader in active US drug master filings, 10 global offices in US, UK, Uzbekistan, Kazakhstan, Peru, Chile, and Mexico, 2,000 plus dossiers filed globally. And coming to the cardiological innovations, MSN has launched the first time in India branded generics, starting from Pulmonext Kit, Selexipag, Selipag, Riosi, Macitent in pulmonary hypertension. And coming to anti-diabetes, we have launched dapagliflozin with the brand name Dapa1, empagliflozin with the brand name Empa1, Lina Next. And coming to hyponatremia management, we have launched Tolvac and we have launched Azilura. And coming to antiplatelet, we have launched Prasugrel with Prasusafe, Ticagrelor with TRA, and Cangrelor with Canreal. And MSN's future research portfolio includes in heart failure, iron deficiency in heart failure management. We are planning to launch ferric carboxymaltose, and coming to in anti-diabetes, we are planning to launch sitagliptin and metformin hydrochloride combinations. To partner in creating awareness in management of pulmonary arterial hypertension, approach for emerging treatment options that to increase the patient's life expectancy and quality of life. Today, we are having a session with Dr. Pankaj Zariwala sir. Pankaj Zariwala sir is a senior interventional cardiologist from Yashoda Hospital, Somajiguda, Hyderabad. He is an ex-assistant professor of cardiology from Nizam's Institute of Medical Sciences, Hyderabad, former associate editor of Indian Heart Journal and associate editor of Journal of Indian College of Cardiology. Dr. Pankaj sir has received numerous awards during his course of journey, like Vaidya Sri Award 2013, Best Cardiologist of Hyderabad, Call for Clinical Case at Euro PCR 2009, and Best Prize for Case Presentation at Midterm Indian Interventional Council. Dr. Pankaj sir has performed more than 15,000 PTCS cases, including complex interventions. And Dr. Pankaj sir has got more than 100 research articles published in various national and international journals. As an expert and super specialist in cardiology, I request Dr. Pankaj sir to take over the session.
Yeah, you need to share the slides, please.
Oh, sure. I hope the slides are visible, sir.
Yeah. So, thank you, MSN, and I think you are the pioneer in the management of pulmonary arterial hypertension. And I think most of the drugs what we are required today for management of pulmonary hypertension. They are available with MSN now, and I'm glad to be there associated. And this is the first meeting we are doing with you on Selexipag. This is a new molecule, and I'm very happy that this drug has been launched by MSN, and it will be available to a lot of patients of pulmonary arterial hypertension. And as we know that pulmonary hypertension was not having any medications till date, and the prognosis of the pulmonary arterial hypertension patients was very, very bad, and their lifespan was very less, and they suffer, their morbidity and mortality is very, very high. And now we are happy that the third drug which has been already been launched, and now the availability is there. So let us go through the what is pulmonary arterial hypertension, and what is the indication of use of this molecule, and what are its doses, what is the side effects, how to titrate, what are the concomitant other medications, how we should use with this molecule, and how the patient will get benefit. So I request to next slide, please. So these are the key points, like we will be discussing on the science of pulmonary hypertension, quickly the cardiologist role, what is the management of pulmonary arterial hypertension, the unmet need, what are the present medications available, their side effect profile, and why we need more and more molecules for the management of pulmonary hypertension, and Selexipag, the novel drug we'll be discussing. The next slide. So the science of the pulmonary hypertension, there is a difference between pulmonary arterial hypertension and pulmonary hypertension. So that is very, very important concept. Everyone should know what is pH and what is PAH. This is very common exam question which was asked to us by when we give our cardiology exam. And if you don't answer this basic question, you are failed in the exam. So this is very, very important. Everybody should know what is pulmonary hypertension. So you should not use the word pulmonary arterial hypertension and pulmonary hypertension to exchange each other. So pulmonary hypertension is any elevation of the pulmonary artery pressure more than 25 millimeter of mercury during right heart catheterization in the resting phase. So this is not during exercise. We do 6-minute walk test, or we do some kind of exercise test also, and stress test what we call, and then we try to see the pulmonary arterial hypertension. But when patient is in a resting condition, when the patient's heart rate, oxygen saturation, blood pressure is normal, during that time when you do patient Hello, sorry for the disturbance. So pulmonary hypertension is classified into 5 clinical groups, like pulmonary arterial hypertension, where the etiology is there in the arterial wall. So there are many diseases which causes the arterial hypertension, and there is a disease of the arterial wall. Then there are pulmonary hypertension due to left-sided diseases. The most common cause of pulmonary hypertension is basically left-sided heart disease. Like patient is having valvular pathology like mitral stenosis or mitral regurgitation or aortic wall involvement or left ventricular dysfunction. So these are all causes leads to pulmonary arterial hypertension, and it is one of the very, very common cause. And the chronic lung diseases, like what we call it as a cor pulmonale. So the cor means heart, pulmonale means lung pathology. So whenever there is a lung diseases, like there are various diseases are there, and like chronic bronchiectasis, or patient is having interstitial lung disease, or because of the right from the there is agenesis of the lung, or there can be patient is having absence of the pulmonary congenital absence of the pulmonary arteries. So right from the congenital causes to acquired causes, there are various causes of the various lung diseases. I think Dr. Rafi, who is a pulmonologist with us as the next speaker, he will discuss about that. And then there is another group which is very commonly seen in COVID era. Also, we had a lot of cases of pulmonary thromboembolism, and many patients, they suffered the pulmonary thromboembolism without their knowledge. I saw many cases after COVID, patients suffered with pulmonary embolism. When we did a CT angiography, we found that they were not knowing that they suffered a pulmonary embolism. And now they are coming up with elevated pulmonary arterial pressure. And there is unknown causes. There are many causes. Idiopathic disorders are there where patients suffer with pulmonary hypertension and multifactorial involvement also. So there are prognosis of the PH has improved little bit these days, but the outcomes of the early detection and accurate diagnosis is very important. So many of the patients, they come to us in late stages where patient has already having dilatation of the right atria and right ventricle. There is right ventricular dysfunction. They come in right heart failure. Patient pressures are very, very elevated. Already patient is having some kind of pericardial effusion, and their exercise tolerance is very less. They barely able to walk a few distance also. Like patient is coming in NYHA class 3 or 4, and then they come to know that they are suffering with the pulmonary arterial hypertension. So early diagnosis is very important because these days we have very good molecules. Next slide. So pulmonary hypertension is an under-recognized global health issue, and by no means is a rare problem. It's a very common problem, and if you do the echocardiography in echocardiography lab, you will find that almost like 30 to 40% patients what we see in our outpatient department, they are having some kind of pulmonary arterial hypertension. So it may be you may think that I am little overstating statement, but it is really a very, very common problem. And many patients, they have mild pulmonary arterial hypertension like a normal individual, and when we do echocardiography, we find that their pressures are elevated, but they are totally asymptomatic. So this is worldwide. These are different data is there, like from Europe. Not in India, again, the problem is we do not have the data, and many of patients, they suffer with heart failure associated with pulmonary hypertension, and moderate to severe chronic obstructive COPD is very, very common. And the problem is when we do echocardiography of COPD patient, their windows are not very good because their lungs are overinflated, and accurate diagnosis of pulmonary arterial hypertension sometimes becomes very problem. Luckily, the HIV associated pulmonary hypertension, HIV, the disease is now in decline because the governmental widespread education and the awareness of the public, the disease is very, schistosomiasis is not very common problem in our country. Sickle cell disease, of course, in some of the pockets we see, but of course is not very common disease. Rheumatic heart disease is very common in our country, but luckily the rheumatic heart disease, chronic rheumatic heart disease is also on decline because of the improved socioeconomic status of the people. The disease is also on decline. So, the main problem which remains in today's world is basically lung-related problems, like the diseases like COVID has surfaced again, and our old friend, that is the tuberculosis, still remains rampant in our country, and there are many other diseases like industrial occupational diseases and interstitial lung diseases and collagen vascular diseases. So all of them, they still pose a lot of problem. Heart failure, left heart disease, as I told, is one of the very common problem, as our patients are surviving more and more because of the interventions, bypass surgeries and angioplasties. They are coming up with the left ventricular dysfunction, and heart failure related pulmonary arterial hypertension is also on rise. So these are the changing scenario of pulmonary arterial hypertension. Next slide. So I will not go into the numbers, and as I mentioned, in economically developed countries, left-sided heart disease and lung disease, as I mentioned, they are far more common causes of pulmonary hypertension. Next slide. So globally, the left heart failure leads to right heart failure, and because as the left heart is unable to pump the blood, there is increase in the pulmonary end diastolic pressure, which leads to increase in the left atrial pressure, and left atrial pressure leads to increase in the pulmonary capillary wedge pressure, and pulmonary capillary wedge pressure leads to increase in the pulmonary arterial hypertension. So the retrograde, the reverse way, the left heart disease leads to increase in, because as the increase the lung pressures because of the left heart disease, the right heart is unable to pump the blood, and that leads to increase in the pulmonary arterial hypertension, and it is going to becoming one of the leading cause. Almost like 5 to 10% of the patient of more than 65 years and older, they suffer this problem. So next slide. So this is 2022 update and pulmonary hypertension in India. This is one of the editorial, and they say that burden of pulmonary arterial hypertension is high in India due to large population base, and we don't have the exact data. The epidemiological studies are not there, population-based studies are not there, and the cross-sectional data in the population-wise is not available in our country, and there is no dearth of highly qualified experts in India. They are not dedicated people, those who practice only pulmonary hypertension as their specialty. And because we are basically a cardiologist who do everything, we are general cardiologists, we are interventional cardiologists, we do manage the cases of pulmonary arterial hypertension also, because there is no other option. And that is what needed, is to get the organized and develop collaborative efforts similar to other countries where the dedicated pulmonary hypertension teams are available, and they do look after these pulmonary hypertension patient, and the expertise team where they do all kind of evaluation for the patient. So basically the diagnosing the pulmonary hypertension itself is one of the challenging tasks. So most of the patients, they come to us with only pulmonary hypertension. You do echocardiography, you will find that patient is having elevation of pulmonary arterial hypertension. So pulmonary hypertension is basically a diagnosis to be suspected, and the patient usually comes with the regular symptoms like breathlessness on exertion, or they come with right heart failure, and maybe just only the breathlessness on exertion, or some kind of chest pain, or syncope sometimes, rarely. So basically it is a diagnosis of exclusion, and once you make the diagnosis of pulmonary hypertension, it do not suffice. There are many plethora of diseases are there, and you need to classify them first, what kind of patient is suffering. And sometimes the pulmonary hypertension may be in a hidden state or in a overt state, and you need to do various tests like 6-minute walk test or stress test, and you have to go for right heart catheterization and various other imaging modalities, and then you come to the diagnosis. Next slide. So we will be discussing those things in coming slides. So this is very, very important classification, and everybody should know about this classification. This is a standard WHO group classification of pulmonary hypertension. And when you are, this classification is not only important from the diagnostic point of time, but from the therapeutic point of time also. So whatever therapies we are going to address in this talk, they are based on this WHO, and the group 1 is very important group, and our most of the therapies what today we have availability is basically for our group 1, and what we call it as a pulmonary arterial hypertension. So as in the beginning, as I told you, there is a difference between pulmonary hypertension. Pulmonary hypertension is basically a broad group where elevation of pulmonary arteries, arterial pressure is called as pulmonary hypertension. But when the cause lies in the arteries, pulmonary arteries, then we call it as pulmonary arterial hypertension. And there are various diseases are there, like idiopathic pulmonary arterial hypertension, heritable causes like familial pulmonary arterial hypertension. Usually idiopathic and familial, they usually overlap, and there can be a familial hypertension, like many people, they suffer with hypertension in the family, and without any cause, and you need to ask them any history of sudden cardiac death, or any, because patients may not be knowing that they are suffering with something, a specific disorder called pulmonary artery hypertension. Drug and toxin induced disorders are also there. And connective tissue disorder is again a very wide disorder. There are many connective tissue disorders are there, right from rheumatoid arthritis, scleroderma, mixed connective tissue disorders, Sjogren syndrome. So these are the various diseases which can lead to pulmonary arterial hypertension. There is basically a thickening of the pulmonary artery because of the collagen vascular disease or connective tissue disease. And HIV infection, again, it leads to the pulmonary arteriopathy, and that leads to the involvement of the pulmonary arteries. Portal hypertension also can cause pulmonary artery hypertension. And what we call it as a portopulmonary hypertension. Again, the prognosis of the patients in this group is very bad unless treated earlier. All congenital heart disease, what we call it as untreated congenital heart disease, what we call it as Eisenmenger syndrome, where patient has been not treated, like ventricular septal defect or atrial septal defect or patent ductus, like left to right shunts, which were unrecognized, were not treated in the childhood, and those patients, they develop. Now left to right shunt became the left to right shunt became the right to left shunt. So these are the different congenital heart diseases. Schistosomiasis, of course, is not very common disease in our country, and it is seen mainly in the African continents, but we are getting a lot of African patients also these days as a part of medical tourism in our country. So that diagnosis also we should be knowing. And WHO pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis. These are the persistent pulmonary hypertension of the newborn. So these are the various diseases included in this group. Group 2 is basically left ventricular, because of the left-sided disease, as I told you, like congenital heart disease, left ventricular systolic diastolic dysfunctions, and valvular heart disease. Group 3 is because of the lung disease, as we said. The next speaker will discuss them. And chronic thromboembolism, because of the occlusion of the pulmonary arteries because of the thrombus which got organized there, and patients sometimes may not give the history of pulmonary artery, pulmonary embolism. And multi-factor like hematological disorders, systemic disorders, metabolic disorders, and all. Of course, they are rare, but we should consider them on regular basis. So that is also very, very important diseases. Next slide, please. So this is basically pulmonary arterial hypertension, and how the usually CT looks like. There is enlargement of the main pulmonary artery, and as compared to the normal, you can see there is a highly enlarged pulmonary artery. So basically, it leads to the dilatation of the pulmonary arteries. And next slide. So there is a functional classification of pulmonary arterial hypertension also, like pulmonary class 1, class 2, class 3, and class 4, similar to our NYHA class, what we follow, like without any resulting limitation of physical activity. And then patient is resulting in slight limitation of physical activity. Mark limitation is called as grade 3, and patient even at rest, without doing anything, patients when they suffer with the problem, that is basically a class 4 pulmonary arterial hypertension. Next slide. So basically the cardiologist's role in the diagnosis of PAH. Next slide. Yeah, so symptoms, signs, and history suggestive of pulmonary arterial hypertension, like somebody who develops breathlessness on exertion. And basically, when we need to suspect that patient is not giving any history of coronary artery disease or any chest pain, like typical what we see in coronary artery disease, but usually many of these patients, they come with unexplained breathlessness. And when you examine some of these patients, like will be having right heart failure, and these patients usually they come to us because of the elevated jugular venous pressure or pedal edema or ascites. All these problems are there, and you need to suspect a right heart failure in this group of patient. And some patient give definitive history, like somebody who is having lung disease or maybe left-sided heart disease. They gave some kind of definitive history, but some of the patients like idiopathic pulmonary arterial hypertension, they may not have specific symptoms. Some of them they present with syncope also. So we need to suspect them, and depending upon the every disease has their own clinical profile and the echo probability of pH. So the all these patients usually they should go for the echocardiographic evaluation. And whenever we do the echocardiography, the pulmonary arterial hypertension is detected. 2D echocardiography is a very, very sensitive method to diagnose the echo for pulmonary arterial hypertension. And these patients, particularly once we do, we need to see whether they have any high probability or intermediate probability of so consider the left-sided disease and lung disease, and the low probability, then you need to go for other diagnosis. Next slide. So basically, this is a secondary signs of pH, and usually we see the dilatation of the right atria, and as you can see in the first slide, the huge dilatation of the right ventricle and right atrium, and the left ventricle is almost became very small. And below that, you can see there is a D sign where the interventricular septum is almost got compressed, and then there is a IVC. You can see in inferior vena cava there is a huge and there is no collapse, and this is basically leads to right heart failure. Usually when they develop this kind of problems. And there is I think there are many other things are there, like pulmonary early diastolic velocity and all. I think it is not able to discuss all these things in detail. We'll go ahead with the next slide, because that becomes echocardiography probability. So anybody is having less than 35 millimeter of mercury pressure is called as no pulmonary arterial hypertension. Between 35 to 50, intermediate probability, and more than 50 when it is there, it is called as high probability of pulmonary arterial hypertension. So these are the various echocardiographic measurements of pulmonary arterial hypertension. Next slide. So basically, echocardiography probability, peak tricuspid regurgitation, and usually depending upon the presence of other signs also, we can diagnose this peak regurgitation velocity. And if it is more than between 2.9 to 3.4, we call it, and other signs of pulmonary arterial hypertension are there, then we say that patient is having pulmonary arterial hypertension. So next slide. So right heart catheterization usually is not done in most of the cases, because if somebody is having severe pulmonary arterial hypertension, the risk of this right heart catheterization is very high. These days, echocardiography is very sensitive, and most of the cases are done by doing echocardiography. Right heart catheterization is usually done for any therapeutic point of time, or patient is enrolled in some kind of clinical trials. Only in those cases, right heart catheterization is done. And usually the person should be experienced enough to do the right heart catheterization. Otherwise, doing right heart catheterization is very, very difficult in most of the patients. And routinely, it is not advocated. Next slide. So cardiac MRI is very, very important thing we should do in most of the patient, because there are various disorders like sarcoidosis and various infiltrative disorders and lung diseases, which can be diagnosed only with the help of cardiac MRI. And cardiac MRI is one of the tool of investigation in most of the patients. So it cannot replace the right heart catheterization, but it gives a very accurate diagnosis. And when many congenital heart diseases, when they are suspected, to know the definitive diagnosis, this modality is very, very important. Next slide. So echocardiographic science, I think we'll skip some of these slides from the point of view the time is limitation. Can you go to the next slide? I think echocardiographic science, right ventricle, all these things, I think they're in too depth. The slides has been prepared. So I request them to go ahead. Yeah, so this is the diagnostic algorithm of pulmonary hypertension. This is very, very important. And we need to treat the underlying cause, and VQ scan needs to be done we need to refer a patient who is having expertise in the pH and VQ scan, and usually mismatch. Usually, most of the time these days, rather than doing VQ scan, we prefer to do what we call it as CT pulmonary angiography, and that is very, very useful for us to do, and because that gives a lot of information to us rather than going for what we call it as a VQ scan. So VQ scan is having limitation, and so Dr. Ramanuj.
Sir.
I request you to stop. I would like to share it.
Okay, sure.
Sorry for the disturbance.
No.
Yeah. Can you see my slides now?
Yes, sir.
Now you are able to see me also. Yeah. So what I was talking is in pulmonary arterial hypertension nowadays we are doing most of the time CT pulmonary angiography, because CT pulmonary angiography is very easy to do and it is cost effective also. And the diagnosis of chronic pulmonary thromboembolism is very easily possible by that, and it is very gold standard, and very accurately you can see the thrombus which is present there. And if there is no mismatch as such, the right heart catheterization, as I told you, is not very commonly performed. We do most of the time echocardiography and maybe required a 6-minute walk test and maybe the stress test to make the diagnosis. And the clinical history is very, very important for the most of these patients. And these are the very, very important tests to be done in this group of patients, like connective tissue disorder. If it is suspected, then most of the time we take the help of our rheumatologist, who makes the diagnosis of the congenital heart diseases and all that can be diagnosed by echocardiography only. Schistosomiasis and all these diseases, because some patients will be coming from that particular area where the schistosomiasis is very, very prominent. And some of the blood tests we do in our most of these patients, like RA factor and viral screening, and history of drug will be there. Portopulmonary hypertension can be easily diagnosed, because most of the time we do the ultrasonography of these patients also. So these are the various plethora of tests which needs to be done for the making of the diagnosis of pulmonary arterial hypertension. So basically the echocardiography probability, when it is high and with other risk factors, the further investigation of right heart catheterization is recommended, but practically it is not possible. So these are some of the unmet needs of pulmonary arterial hypertension and challenges in the diagnosis and treatment of pulmonary hypertension. Like multi-center referral study was done in REVEAL registry, and at the time of the diagnosis and referral, 61% of the patients in this study were already in the advanced stages of disease, and only 30% of the patients were already on some kind of PAH specific medication. So the unmet need, despite the drug discovery and development of pulmonary hypertension, it is a devastating condition. And as you can see, the
by the time of diagnosis, even the 36 months, there is a downfall, and many of these patients, the survival is very, very less. And within 3 to 5 years, almost 50% of the patients, they are dead. They usually die. And several studies, they indicated that 50 to 70% patients with severe aortic stenosis, they develop pulmonary arterial hypertension, and associated about a double increase in the mortality risk. So heart failure with preserved ejection fraction also is very common, and heart failure with reduced ejection fraction and valvular disease also leads to pulmonary arterial hypertension, which is one of the very, very common problems. So once the pulmonary arterial hypertension develops, whether patient is having idiopathic pulmonary arterial hypertension, or because of the left heart disease, or because of any lung disease, the downfall of the patient is very, very, very rapid, and the survival of these patients is not very, very highly beneficial. And if this early intervention is done, once you recognize, you can improve the prognosis. As you can see, the blue color, the regular monitoring and escalation of the treatment prevents the downfall of the patient as compared to the late intervention. So the treatment goals, like functional class, should be 1 to 2, normal size of the right ventricle, and the 6-minute walk test should be more than 380 to 440 meters, and B nitrotic peptide should be normal. So these are the various treatment goals of the patient, and there are advances in the therapeutic interventions for the patients of with pulmonary arterial hypertension has developed, and there are various drugs are there, like endothelin pathways and nitric oxide pathway and prostacyclin pathway. So till now we were having only 2 drugs, like endothelin pathway inhibitors, like endothelin receptor antagonist. We were having like selective and dual endothelin receptor antagonist, and nitric oxide pathways like PD inhibitors, which inhibits the degradation of this nitric oxide. And the nitric oxide availability, drugs like which inhalation forms of nitric oxide, which is not very popular, and it is very cumbersome. But nitric oxide inhibitors are very widely available, like sildenafil and tadalafil, and that leads to the increased amount of nitric oxide in the arterial wall. And prostacyclin pathways were lacking actually. There are various drugs are there, inhalational forms of intravenous forms, and now we have agonist also. It's like oral, as I told you, PD inhibitors like sildenafil and tadalafil, and endothelin receptor antagonists like bosentan, ambrisentan, and macitentan, and soluble guanylate cyclase stimulants, which very commonly is used in patients of chronic pulmonary thromboembolism like riociguat, and prostacyclin receptor antagonists like selexipag. Prostaglandin analog, as I told you, IV and subcutaneous drugs like treprostinil and epoprostenol, they are not available in our country, but it is very difficult to use them, and there are a lot of complications of continuous infusion needs to be given to the patients, and that leads to a very, very difficult problem. So now selexipag is very, very available in the treatment of pulmonary hypertension, and basically it is a selective oral prostacyclin receptor agonist for the treatment of pulmonary arterial hypertension. So there are various other drugs are also there, but Uptravi, it is available as a drug called Uptravi, and it is approved from 2015 to treat the pulmonary arterial hypertension. So Griffon was one of the very landmark study which was done in pulmonary arterial hypertension on prostaglandin I2 receptor agonist in pulmonary arterial hypertension. It was a large international multi-center long-term phase 3 trial of double-blind placebo control event-driven trial, and the time to first adjudicated morbidity and mortality were studied in this group of patients. So almost more than 1,100 patients included and treated up to 4.3 years, and 80% patients were available on background treatment like endothelin receptor antagonist, PD inhibitors, or both. And up titration of selexipag allows these patients on maintenance dose to be individualized based on the tolerability to the maximum of 1600 microgram twice daily. So first time to first occurrence of death or morbidity due to pH were studied in these morbidity or mortality events like disease progression or hospitalization for worsening of pulmonary arterial hypertension, initiation of parenteral prostaglandin agonist or chronic oxygen therapy for worsening of pH, or patient requiring any lung transplantation or atrial septostomy. These are all treatment usually used in the end stage disease and all cause death like sudden death or patient dying because of the chronic heart failure. So patients with WHO functional class 2 to 3 at baseline and the decrease in the 6-minute walk test, like this is what the measure of the disease progression, like patient is a stable patient, but they have decrease in the 6-minute walk test or by almost 15%, or worsening of the functional class, like somebody is in functional class 2 becomes functional class 3, or if somebody is in functional class 3 becomes functional class 4, and there is a need for any additional pulmonary arterial hypertension, like somebody who is stable on PD inhibitor and you require to go for endothelin receptor antagonist or any addition of second drug or addition of third drug, that is also called as worsening of the patient. So that is Griffon trial. Usually selexipag reduced. So in this trial, the primary composite endpoint of significant treatment favorably, if you see, as compared to the placebo, when this drug was given without any event, selexipag reduced the risk of morbidity and mortality primary endpoint by almost 40% compared to the placebo. That was very, very statistically significant. And you can see the curve started separating within few months of the starting of the molecule. So by the 6 months of the therapy, already the curve started separating. And by the 36 months, the selexipag was very, very useful molecule. And the different group of patients were across the subgroup analysis, like patients on endothelin receptor antagonist, PD monotherapy or without any therapy also, and in different functional class 2 to 3. So the sex, male, female, different age groups like more than and less than 65, and different kind of pH. Basically, this drug you have to use in patients of group 1 WHO class, as we saw in the classification. And that's why I told you that this WHO classification is very, very important. And you need to use this drug exclusively for patients of group 1 pulmonary arterial hypertension, what we call it as PAH, and idiopathic hereditary pulmonary arterial hypertension, HIV associated, drug or toxin induced, and connective tissue disorder and congenital heart disease, corrected congenital heart disease in this group of. So conclusion of Griffon, this was published in New England Journal of Medicine already in 2015. And this Griffon study made its primary objective of the patients with pulmonary arterial hypertension, and there was a risk of the reduced risk of morbidity and mortality by almost 40%, and efficacy was seen across all the groups of age, gender, functional class, etiology, and background therapy. And there is overall tolerability profile of selexipag in Griffon was consistent with prostaglandin therapy, and the patient received for median of almost 70 weeks, and it reduced the primary endpoint of reduction by. So dose titration, like 200 microgram, you have to start twice daily is a starting dose, and then at weekly intervals, because depending upon the tolerability, you can go to 400 micrograms, then 600 microgram, 800 microgram, and 1000 micrograms. So continue as tolerated doses to the maximum dose of 1600 microgram twice daily. And if dose is not tolerated, then similarly you can down titrate the dose of the patient. So weekly interval or maximum at least twice weekly interval you can go. And those who have moderate hepatic impairment, starting dose of 200 microgram once daily, and then you can increase 200 microgram once daily at weekly intervals to the highest dose of 1600, can be depending upon the tolerability. So the consensus survey on treatment of pulmonary arterial hypertension with oral prostacyclin pathway agents, they recommend that the panel identified 13 clinical scenarios in which selexipag can be considered. And like patients of idiopathic pulmonary arterial hypertension and low to intermediate risk hemodynamic parameters, like functional class 1 and functional class 3, and patients of connective tissue disorder with pulmonary arterial hypertension, and those who have idiopathic pulmonary hypertension, or patients of connective tissue disorder with high risk hemodynamic parameters are there. In this group of patient, already patient is on dual therapy of ERA and PD inhibitors, and still patients are symptomatic. In this group of patient, you need to consider. So by patients of functional class 2 and low risk and intermediate risk group, those who are hospitalized in the last 6 months, and there is no hospitalization, but patient has moderate to severe right ventricular dysfunction. So in this group of functional class 2, we need to start the selexipag in this group of patient. And also the functional class 3, those who are already functional class, but even though they are not hospitalized, but patient is in functional class 3, and intermediate risk group, that those who were hospitalized, but and also they have mildly impaired right ventricular dysfunction. So these are basically 1, 2, 3, 4, 5, 6 group of patient where you need to start the selexipag. And functional class 2, those who have connective tissue disorders, but intermediate risk group of patient, and again they were hospitalized, but they were having some kind of hospitalization or RV dysfunction or elevated BNP levels. And these are some of the patients of abnormal RV dysfunction, not intermediate group of patient, not hospitalized, but they have the 6-minute walk test less than 440. And functional class 3, hospitalized patients and intermediate risk group of patient, even despite they were not hospitalized, we need to start them. And those patients who were hospitalized or they were having mildly impaired RV dysfunction. So the take home points: pulmonary arterial hypertension is a disease of cardiopulmonary unit, and it affects the pulmonary arteries and venous circulation and right ventricle, and it is under recognized problem globally. And early diagnosis is very, very important for the improved prognostication of the patient. And as we have the triple drug combination is available nowadays by targeting different pathways of pulmonary arterial hypertension pathogenesis, like prostacyclin, nitric oxide, and endothelin pathways, we will be able to do a justice to our patient, and the deterioration of the patients will be decline in the patients of the condition will be minimized now. And selexipag is one of the very important non-prostaglandin agonist selected for IP receptors, which mediates the vasodilatation of the pulmonary vasculature, approved by US FDA way back in 2015. And now we are getting this drug in India, and I welcome this molecule, which actually the MSN lab has done a very good thing, that bringing this molecule, and I think they are the pioneer of this drug. And they were actually planning to bring this drug very long back, and the discussions were happening almost more than 2 years, but there were certain issues, and I think COVID pandemic also affected the introduction of this molecule in the Indian market. And as we said, that is very useful drug which reduces the morbidity and mortality by almost 40%. So thank you very much for your patience hearing, and I give the back to the people from the MSN lab. Thank you for the patience hearing.
Sir, we have one more speaker, Dr. Rafi sir is a senior consultant and international pulmonologist from Care Hospital.
Anybody from the MSN, Mr. Ramanuj?
Yes, sir. Am I audible, sir?
Yeah. Hello.
Yeah, sir. Am I audible, sir?
Hello, Dr. Rafi.
Hello, Dr. Pankaj. That was an excellent presentation. I thoroughly enjoyed it. Learned a few points as well.
Yeah, thank you, sir. I think we need to give it back to MSN.
Yes. It is a timely introduction of the molecule in the Indian pulmonary hypertension patient pool, where we are missing the options of one more addition with the non-prostanoid kind of drug. So should I start my?
Yeah, please, you can start.
Yeah,
sir.
looks like we are short of time as well. Yeah, I'll share my screen.
Yeah, sure.
Ramanujan?
Yes, sir. Sure, sir.
Okay. Able to see my screen?
Yes, sir. Yes, sir.
Yeah. Okay.
Yeah, that's perfect, sir.
Okay. Well, after the extensive elaborate detailing done by Dr. Pankaj, looks like my job is cut down. I think probably I'll wrap up real quick, and then not to keep even the listeners who are there to be really wondering that the information shouldn't go over the head. Okay, so we are looking at this selexipag in treatment of pulmonary arterial hypertension and a pulmonology perspective. So I think only amongst the groups, as you have seen, only one group seems to be on the pure pulmonology side. I think I would be speaking about only those, which is in a common term when we hear it is a carpulmonale patients of various reasons. When we look at the 6th World Symposium on Pulmonary Hypertension, what's the old and is what's old is new now, as this actually in the journal they have mentioned about the unclear or multifactorial mechanisms for the pulmonary hypertension, the hematological disorders like a chronic hemolytic anemia, myeloproliferative disorders, systemic and metabolic disorders. Some of them have been picked up unknown, very remote diagnoses like pulmonary Langerhans in our practice, chronic renal failure without hemodialysis, fibrosing mediastinitis, complex congenital heart disease. All these things could be the causes. When you see purely on the pulmonary point of view, we can say that just pulmonary hypertension due to lung diseases and or hypoxia could be falling in the groups obstructive lung diseases or restrictive lung diseases like ILDs, obstructive lung diseases like chronic COPDs or tuberculosis or COX, tuberculosis or bronchiectasis, sequelae, damaged lungs, other lung diseases, mixed or restrictive obstructive patterns. If you see a CPFE, what we call it as a combined pulmonary fibrosis and emphysema drug is also one of the things which can cause this hypoxia without any lung disease. These their developmental lung disorders. We mentioned about some agenesis and these kind of disorders. Broadly to see as a spectrum, pH due to COPD, the potential explanations for severe pulmonary hypertension, COPD, when you see pH due to COPD or COPD and pH coexisting. These two scenarios can happen. Hypothetically, in patients with COPD, severe pulmonary hypertension may occur as a consequence of an aggressive form of pulmonary vascular disease, that is pH due to COPD, or because of there is a coexisting pulmonary hypertension. So both scenarios can happen. Something like, this is something like if you're pulmonology clinicians or something, ECOS has been there, COPD, asthma coexisting, or as purely COPD, purely asthmatics, chronic asthmatics turning into secondary COPD. So COPD pH due to COPD or COPD pH coexisting, both can happen. Hemodynamic classification of pulmonary hypertension in COPD, when you see, this has already been mentioned by Dr. Pankaj. So the pressures without pH, COPD without pH, we mean pulmonary artery pressure should be less than 21 millimeters of Hg, whereas COPD with pH which should above 21 to 24 or 3 Wood units, vascular resistance about 3 Wood units, mean PAP about 25 to 34. COPD with severe pH, PAP would be more than 35 millimeters of Hg. Confirmed and suspected factors leading to an increased pulmonary vascular resistance in COPD. Factors of pH in COPD usually happens consequences on pulmonary vessels, basically like causing an airflow limitation, which causes a pressure swings. Emphysema causes reduction in the vascular bed. alveolar hypoxia causes the vasoconstriction, and then remodeling. Hypercapnic acidosis causes the vasoconstriction, polycythemia, and then hyperviscous. See, these are the polycythemia, lung and systemic inflammation. All these things are factors you can actually point out in the pH in COPD. So consequently, if you see the micro level, what are the things which is having the pressure swings, reduction in the vascular bed, vasoconstriction, remodeling, and then causing hyperviscosity and including fibrosis. That's why we see even the even post-infectious fibrosis, like even COVID fibrosis, in some cases leading to secondary pulmonary hypertension we have seen. In severe emphysema, and then pulmonary pressures, arterial pressures and pulmonary vascular resistance were weakly correlated with the diffusing capacity of the lung for carbon monoxide, suggesting that in patients with markedly predominant emphysema, loss of pulmonary capillaries. So I want you to stress on this point. Usually the point which to be like loss of pulmonary capillaries may play a role in the development of the pH in the PAH. So this is a pictorial form, pulmonary muscular artery from a patient with chronic obstructive lung disease. Immunostaining with a monoclonal antibody against a smooth muscle actin, showing abundant proliferation of the smooth muscle cells in the intima here. And in another stain, Orsin stain disclosing abundant deposition of elastic fibers in the intimal layer and interscale, this causing a narrowing of the airway and then causing a pressure increase. Assessment of the pulmonary vascular phenotype. Phenotype in COPD, usually the clinical features would be like a exclusion of other causes of pH, chronic thromboembolic, where VQ scintigraphy were done, left heart disease, echocardiography, right heart catheterization, sleep breathing disorders, risk factors for pH like HIV mutation, BMPR2 mutation, portal hypertension, connective tissue diseases. All these have been looked at. Pulmonary function testing and when you do forced spirometry, DLCO and arterial blood gases, and imaging techniques, high resolution CT scan, assessment of extent and severity of the emphysema, right heart catheterization, as spoke about extensively by Dr. Pankaj, mean gap and then cardiac index have to be looked at to diagnose. Cardiopulmonary exercise testing is the one also be looked at. Cardiovascular limitation pattern, preserved ventilatory response, gas exchange inefficiency, low end tidal carbon dioxide, and with the high slope with V by CO2. Circulating biomarkers, either usually we are using rampantly or BNP or anti-proBNP as well. Risk of death due to pH and failed features in different pulmonary vascular disease phenotypes in COPD. When you see COPD with the pH, risk of mortality due to pH is little less, where the FEV1 is reduced in these patients, DLCO is reduced or to normal, 6-minute walk test or cardiopulmonary exercise testing performance reduced, partial pressure of arterial oxygen is reduced or normal. Pulmonary hemodynamics, like mean PAP is less than 20, mean PAP between 21 to 24 or less than 3 Wood units. These are all considered with the COPD without pH, COPD with post capillary pH. So that is when you can see the change happening. Even both DLCO 6-minute walk tests show a dip. And then if you have a proportionate mild to moderate pH, you would see a ventilatory limitation also in the same 6-minute walk test. And pulmonary vascular phenotype would have absolute FEV1 decrease. So there is not much of FEV1 decrease in pulmonary vascular phenotype, like a typical COPD. So in those patients, basically a cardiovascular limitation is more. And then the arterial pressures of oxygen is much, much lower. Proposed algorithm for treatment of pulmonary artery hypertension based on 6th World Symposium. You have seen this and an advanced form by the other speaker as well. You have referral to pulmonary hypertension center, vasoreactive testing. You can do a simple calcium channel blocker therapy or versus non-vasoreactive, low, moderate NYHA 2 to 3 risk initial therapy. Combination therapy started with the either ambrisentan or tadalafil or macitentan or sildenafil, one of the above combinations plus selexipag. Also consider riociguat and bosentan depending on the categorization. High risk NYHF initial therapy is parenteral epoprostenol only. I think it is also mentioned by the other speaker, which is not available where it is high risk in doing a infusion in a patients. Consider referral to the lung transplantation center as a last option. Excuse me. When you look into the specific therapies, especially 3 signaling pathways, we have seen endothelin pathway, cyclic GMP pathway, and prostacyclin pathway. So endothelin receptor antagonists, you've seen ambrisentan, bosentan, macitentan, already told. PD inhibitors are gynocyclic simulators are riociguat. PD inhibitors are sildenafil, tadalafil. Prostanoids are epoprostenol or beraprost, iloprost, treprostinil, and newer derivatives selexipag has been the need for therapy in COPD with PAH. So the studies which are shown that endothelial dysfunction plays an important role in pathogenesis in PH and COPD. However, data supports to the use of PH specific therapies in the patients with PH secondary to the chronic parenchymal lung disease are limited. Usually randomized study used in bosentan in the treatment of PH in COPD patients with stage 3 or 4 without severe PH at rest for 12 weeks resulted in worsening hypoxemia, while in another non-randomized study, bosentan showed a significant functional improvement in those COPD stage, gold 3 to 4 categories. So the use of sildenafil and other drug like iloprost in the same types of patients resulted in hemodynamic improvement without significant clinical benefit, but instead it worsened the hypoxia. And then when you see this selexipag, this slide you have seen starting from 200 micrograms twice daily for about first week to almost each week escalating to about 200 mcg dose twice, increasing on the dose up to, you can go reach up to 1600 mcg of the tolerable high dose. Moderate hepatic impairment, if it happens, you can descale. Selexipag, an oral selective prostacyclin receptor agonist for the treatment of pulmonary hypertension. You've seen multi-center double-blind placebo-controlled study has been 17 weeks duration mentioned. Especially inclusion criteria have been idiopathic or familial CTDs related, correlated congenital or anorexogen use related PH. Stable background therapies have been already tried in those patients. Those are the ones who have been included in it. Baseline RX is showing peripheral vascular resistance up to 400 dynes, more than 400 dynes per square centimeter. 6-minute walk test is 150 to 500. Results, they looked at statistically significant treatment effect, reduction of the pressure by 30%. Selexipag was well tolerated with the safety profile in line with that of the expected pharmacological effect. So when we look into the efficacy of this drug, it is this event-driven study, and it's shown that the risk of primary composite endpoint of the death or a complication related to PH was lower amongst those who received selexipag than those who haven't received, who are on the placebo. The treatment effect was driven by difference in the disease progression and hospitalization. So addition of selexipag to a baseline regimen of 2 medications for pulmonary artery hypertension resulted in benefits that were consistent with the overall treatment effect. Also, we mentioned earlier by the Pankaj. Role of selexipag in the chronic obstructive pulmonary disease, when you look into specifically pulmonary disease patients without proportion pulmonary hypertension, there's age characteristics are typically 70 and above, sex is almost 70% patients were females, race is, they looked at this study in the Caucasians, body mass index have been 30, obstructive sleep apnea. So almost all those patients who had increased BMI and then OSA as well. Hypertension, diabetes, pulmonary embolism is only in 17% of the patients. Smokers, 67% were the smokers. These have been looked at. Changes in 6-minute walk test over 6 months of selexipag treatment. If you see these graphs, changes in 6-minute walk test with the selexipag seems to be showing a upswing to the higher distance covered by the patients who are on this drug. Change in the mean pulmonary artery pressures, if you see, there is a downswing, down slope in the and then to the lower pressures when they are on more than 6 months. So this is again mentioned in a thing. So in a case series of COPD patients without proportion pulmonary hypertension, the use of Selexipag was associated with a trend towards improvement in patients' functional status, assessed by a 6-minute walk test and reduction in the mean PAP at 6 months. Pulmonary vascular resistance also showed a significant decrease with, from the 7.5 to 4.7 Woods of units mean change to 2.8. Cardiac output and cardiac index improvements were also noticed as a follow-up. So a landmark trial, which has been mentioned by Dr. Pankaj, Griffon trial, primary endpoint across, has shown a very consistent results in all age groups and then the all class of the PH therapy-based categories. Why Selexipag? PH is known independent prognostic marker of COPD. Pulmonary hypertension patients with COPD is associated with an increase in the risk of COPD exacerbation, increased hospitalization, worse survival in this population, reduce the risk and mortality morbidity event with the primary endpoint by 40% compared with the Selexipag. With the placebo, efficacy of Selexipag was consistent across subgroups. We've shown the graph all PH etiology and the background PH therapy as well. So overall tolerability profile is been very consistent with prostacyclin therapies. Patients in the Selexipag group received it for a median duration of 70 weeks. So in PH and COPD patients, Selexipag helps in the functional improvement as well as the improvement in the pulmonary vascular resistance and cardiac parameters as well. So this is a brief plucking out from the extensive presentation by previous speaker, where only pointing it towards the pulmonary point of view. Yeah, thank you. Any questions? Hello?
Yes, sir.
Yeah.
Yeah, Ms. Nutana, any questions? Can you please post the questions?
They're in chat box.
Yeah. So there is a, I can see the question here. Can we initiate a Selexipag as a starting PH treatment? Yeah, I mean, anywhere as a starting treatment. So that is something which has to be, multidisciplinary. I would say cardiologists should also agree when we are doing it, especially selected to the pulmonology point of view, at least at category 2 and above, patients can be decided upon to start a Selexipag safely, because it has shown in the landmark trial being very well tolerated in all functional groups. And I see a question, anything here? What may be the hurdles to use Selexipag in PH associated with the COPD? I wouldn't see in the COPD patients, the hurdles would be if the patient has, might advance very fast into the right heart failure. If it is, we are introducing the drug in too late, probably the benefit I am having my own so to see. But still, I mean, when you have the option to start the drug. There is also one more question I am seeing here. Role of Selexipag in the ILD. I think this has to be seen, because all functional classes we said where the pulmonary interstitium or the capillaries where it can cause changes, role of Selexipag in the ILD is expectantly should be able to be useful, but I think we need to see, need more data in the usage of this drug in those pool of population and to be confirmatively say. But I think that the landmark trial is actually took CTD related ILD and then secondary pulmonary hypertension patients also seems to be showing a benefit with this drug. Mortality benefit, you are asking, is there any mortality benefit shown with the Selexipag? I think I answered this question, and now Dr. Pankaj as well. 40% primary endpoint seems to be a better, 40% of the people have seemed to shown, benefit in the mortality benefit. What will be the dose of moderate hepatic impairment? That is another question I'm seeing in the chat box. there is no clear-cut dose, because individually they might vary. That's why you start off with the 200, and then what is the optimal dose where you can actually titrate to the patient, and then descale if it is there hepatic dysfunction with this drug. And I'm seeing 1 or 2 questions. I can wrap up. If you are starting with the dual combination therapy, should we start both drugs simultaneously? I think this question I would like even Pankaj to get in and then say, if we are starting with the dual combination therapy, should we start both drugs simultaneously or start them sequentially with the second drug being introduced after a short interval, say a couple of weeks, to allow the patient to get used to the first?
Yeah, I think in patient, those who are high risk cases, like where we see patient is having right ventricular dysfunction, or those who have suffered heart failure, hospitalization, I think they're already advanced cases of pulmonary arterial hypertension. And I think they need to be started with triple drug therapy. Even the WHO recommendation and also the European Respiratory Association, ERA, what we call it as, and ESC, there is a common guideline is there with European Society of Cardiology and Respiratory ERA guidelines. They say that in all high-risk group of patients, the triple drug therapy should be given. So actually, unfortunately in India, we were not having the triple drug therapy. This is the first time the Selexipag is available. So we were only using dual therapy in our most of the patient. That was very unfortunate thing. And in patients of intermediate risk, we usually give single therapy or dual therapy. And as I demonstrated, there are 13 points where we should start the Selexipag depending upon the patient. So patient going on Selexipag may change over a period of time as his disease progresses. So he may become from low risk to intermediate risk or intermediate risk to high risk. So the thing is, depending upon the 2-3 things are very, very important that we need to remember. We need to do the BNP levels of all these patients. BNP levels, when they are elevated, it is better to start Selexipag, because already the BNP levels elevation means there is a stretching of the atria and ventricle, and patient is already in the advanced stage. Already those patients, those who were hospitalized for the heart failure, they should be started, and any dilatation of the right ventricle with right ventricular dysfunction, they should be started on the therapy. So I think this is very simple to remember, the 3 things: hospitalization, elevation of the biomarkers, and echocardiographic parameters showing the right ventricular dysfunction. So I think in all these group of patients, better to give triple therapy, so that actually our aim is to reduce the to halt the progression of the pulmonary arterial hypertension. So if we start early therapy, patients will get more benefit.
Yeah, I think that answers the question in the chat box, lucidly explained by Dr. Pankaj. So Ramanuja, is there any more extra questions we can wrap up?
Yeah, yes, sir. Sir, I have only one slide to show, sir.
Yeah.
So we have introduced the first oral prostacyclin receptor agonist, sir, to delay the progression of PAH in WHO group 1, that is Selipags are our brand name, Selexipag 200 and 400 micrograms, sir, the trusted partner of every stage of PAH. So this is the brand we have launched first time in India, sir. I hope our colleagues would have come and introduced to you. And we may be the young player, but our drive and enthusiasm are the best in associating with you, sir. So thank you very much. Thank you very much, Dr. Pankaj sir and Dr. Rafi sir. In spite of having the other assignment, still you could make it for today's program. I am sure, sir, the session is very informative. And thank you so much. And I also thank all our respected audience across India who are present in today's session. So thank you one and all once again, sir. Thank you so much.
Thank you.